All right. Well, it's a real pleasure to have Rosemary Mackenzie on the show today. Welcome.
Yes, thank you for having me.
So I got a lot of questions about testing and perimenopause and all of these things. And I'm not sure where to start, but I think we need to start with what a lot of women are experiencing, what they're hearing. They'll go to their doctor, they ask for their hormones to be tested, and the doctor says, oh, you're in perimenopause, it's useless. Tell us why doctors are so reluctant to test.
Sure. Well, I think previously there was limited ways to track hormones. And so if we think in the past it was serum values, and if you have no context to where someone is in their cycle, if they are cycling or their cycles are really far apart, a one-time test really doesn't tell you anything. And so a lot of providers were like, there's no point in testing hormones. But really, what we're missing here is that the hormones do change, but in a way that we can track them and make it very useful. So I'll show a quick chart example for those who are watching, where this is what women are really experiencing, but you would not capture this in a blood test. So I'll give some.
Maybe explain, yeah,
Yeah.
what we're looking
So
at.
so this is a patient, she's 45, she reports irregular cycles. And if she would go to her provider and say, can I have my hormones checked? The provider probably will say no. But if they said yes and said, go ahead and just go to the lab. So this person, I'll get a little cursor for those who can see me.
And this is and what we're looking at is a chart that's our hormone charts, our estrogen, progesterone, FSH, things like that. So for the people who are listening to the podcast, please go to YouTube. You're going to enjoy this so much more. We'll try to describe it for you. So what we're seeing is just those curves that a woman goes through cycle for the month, right?
So the red here on the beginning of the chart is the period. So we know that kind of begins this cycle of data. So here we have bleeding days at the beginning, and then we progress. This patient ended up with about a 50-day cycle. So for those who can't see it, what this woman experienced was for the first 25 days of her cycle, she had one hormone pattern, and then it completely switched the second half of her cycle. So the next 20 days, we have a new pattern. And so if this person had gone and got a blood drawn in the first 25 days, any day in here, the blood work would have come back saying one thing: high FSH, low estrogen. And that's true. That's what happened right there. But if she happened to get her blood drawn the next 25 days, the results would have said something completely different. It would have said very high estrogen, low FSH. Both were true events. The woman actually experienced both of them, but the blood test really would not show you any of that. It would have just said one or the other, when really this woman experienced both. And so that's why I think in the past we've been resistant to do blood hormone testing, because it really just didn't give us the entire picture. And how do we make a decision off of one snapshot in time blood test? Because if you went down one pathway, it would have been true only half the time. And if you went down the other pathway, it would have been only true half the time as well. So this really is, one of the reasons why there's resistance.
Can I share something as well? So if somebody's looking at this curve, like you said, the first, I don't know, it was like 20 days, 25 days, she's flat estrogen. And then it just skyrockets and up and down, up and down. Yes. And so what a woman presenting to her doctor, if the doctor says, well, we're just going to go by symptoms, forget the testing. And if they were to tell her symptoms saying, okay, I feel symptoms of low estrogen. Let's say she's got hot flashes and night sweats and just the classic symptoms. And the doctor would maybe put her on some kind of a starting dose of estrogen, which I don't know how long, everyone's different in terms of time to kick in. But I imagine from day 25 up to day 50, if she's making her own estrogen and she's taking estrogen on top of it, she's going to feel like tender breasts and may feel worse. And so this is where it's so hard when you're in perimenopause to actually find your dosage.
Yeah, that's exactly what we see happen sometimes. If this person had gone and got her blood work done, we know you have to wait for the result. Then the doctor has to review it. Then they have to decide what they want to do. So maybe they say, you have low estrogen, let's go ahead and do your patch. So then they prescribe the medication. There's a delay, either it's getting mailed to you or you go pick it up at the pharmacy. So by the time you put that patch on, you may have actually not known, but you're superimposing an estradiol patch on top of your own ovary now producing the estrogen. And so you put the patch on, and some women may feel good for a couple of days, a week, and then they feel bad. And they're like, what changed? What happened? And so previously, again, we really couldn't tell what was happening, but now we can see when this kind of superimposed estrogen on top of estrogen. And we know that this, of course, is not going to make anyone feel well. And we've had patients go and get their blood drawn, and their estradiol is through the roof, and the doctor's like, you need to stop that patch. And I agree, they do need to stop that patch, but it's not the patch that's doing this. It's actually their own ovary that's overproducing estrogen. I like to give the analogy of this specific chart example. Pretend that your ovary is a glass ketchup bottle and your brain is tapping the back of that ketchup bottle trying to get some out. And we have a lot of tapping going on in this chart. We see 25 days of high FSH. So we have a lot of feedback from the brain to the ovary, make estrogen, make estrogen, make estrogen. And then like a glass ketchup bottle, finally that lets go of the ketchup and it goes blit all over. And you have way, way too much, in this example, estradiol. And you're like, what was that? Well, sorry, 1 second.
Okay. And just so people know, because if you're listening on the podcast, we have a literally day by day of chart where someone's tested all of these hormones through urine metabolites, but through urine. So you can see that a day by day blow. And that's what we're actually looking at. This is a real person who's really tested all of these data points. And it's kind of like what actually happens rather than just a couple of blood draws during the month, if you're lucky.
And again, no one wants to get there. Go ahead. So what I was just going to comment, what you were talking about is, again, before really there was less utility of tracking hormones in blood because no one wants to get their blood drawn that often to really see those patterns. And so we really were kind of limited to symptoms only. So then symptom only became kind of now the standard practice. We just base things off of symptoms. But the problem with basing things off of symptoms are not all the hormones follow or the symptoms follow the hormones. One patient may say, yeah, I have all the same symptoms, but their actual hormone patterns are different. And so seeing the hormone pattern and the symptoms at the same time, then as a user, you can say, when I have this hormone pattern, I get these symptoms, not what my friend has or what the general population has. It's really more individualized and what is your experience.
Yeah, it's one of the things I would say. I mean, I'm pro testing. I really like it. And I understand the argument now based on especially what you said, why doctors don't want to test. And it makes sense because you're just like taking a shot in the dark. So I usually would recommend, if you can afford it, if you can do it, get several blood tests over time and maybe you'll see some pattern there. But that's before I knew about at-home urine testing. And I was like, and I know of things like the Dutch test or 24-hour urine test, and this is a 24-hour measurement. And that actually shows something completely different. It's a different panel altogether. And I think it has different uses, but we couldn't base our hormonal patterns on just 24 hours either.
Correct. I mean, I like to explain to someone, it's like if you think of in the past when we tracked glucose levels. Well, if you just randomly did a glucose without purposely being fasted, does it actually tell you anything? No. So you had to go to the lab fasted to get your glucose. Well, that was great, but it still didn't tell us how you responded to eating. So then we would have to time the glucose, about an hour after you eat. It gave us another data point. But now when we look at a CGM, how much information do we get off someone's glucose levels off of a CGM versus those previous ways we were doing it? So really this type of at-home hormone testing is the same thing for a CGM for glucose. We're taking what we use in the past because we had to, and now we're really just blowing it open and we can see everyone's hormones, how they're changing dynamically for you and that entire picture. So just like, again, a finger stick or a blood draw for a glucose is right now. A blood draw for a hormone level is right now. They're single, I like to say like single frames. And a CGM and at-home hormone testing is like a movie. You see the entire progression of how everything is happening. And so that now single frame makes sense. You can have the context around it.
So let's kind of explain for everybody all these different types of testing. When we have the blood test where you just take a blood draw from your arm, you have spot testing. I mean, I don't know if the blood spot, I don't know if you could test hormones that way, but there's cortisol testing, urine testing, and then there's this at-home kit testing. Maybe walk us through all those what are the differences among all of them, and what are the purposes, because they all serve something different.
Sure. Yeah, they do each have their own purpose. And so if you need to know what's available in your bloodstream right now, then it's blood. The answer is blood. If you want to know how your hormones are changing over time, really urinary metabolites in an at-home setting is king for this, because you don't want to go to the lab over and over and get your blood drawn. Even if you went every other day, which would be brutal, you're still not being able to see the entire hormone pattern. And no one wants to do that cycle after cycle. So for someone, especially with irregular cycles, maybe you only get a bleed, sometimes it's 60 days, or maybe you went 90 days. You're not going to do your blood every other day for 90 days. That's just not practical. And again, no one really wants to get their blood drawn that often. So if we think about some of the other tests, like spot checking, so you're pricking your finger, collecting blood, that has a use. Sometimes you can get it yourself instead of waiting for a doctor to order it for you, but it's still a delayed result, right? You collect it, you send it in, you wait for the result to come back. So it's still in the same category of single snapshot in time testing. And if we're doing anything that's hormone related, by the time you get it back, it's already like a delayed cycle, right? It was a cycle ago. So that told you what was happening last month or last cycle, but not right now. And so I'll say the biggest difference is, do you need to know something that doesn't change very often or quickly? Then let's do maybe blood or saliva, something like that. But if you need to know how something is dynamically changing, then especially hormones, we're talking about typically urinary metabolites and in an at-home setting.
So I think a lot of listeners already are familiar with the Dutch test or 24-hour urine test. And
Sure.
this is where they collect urine in a bottle for 24 hours, or you put it in a little cup and then you put these sticks and you just dry them and then you wait 24 hours and you send them. Tell us, it does show your urine metabolites or hormone metabolites, but what else what do those kind of tests actually show a doctor other than the metabolites?
Yeah. So if we think about any of those tests that you just mentioned that are collecting specimens over a cycle, like a cycle mapping, so that can be with Dutch or ZRT. So you're collecting urine over a time frame and then you're mailing it in. That's trying to do the same thing that urinary metabolites at home is doing, but it's collecting over a period of time, mailing it in, waiting for the results to come back. So in that way, really the at home is replacing any time that you're collecting things over a duration of time and then mailing it in, waiting for the results. But where at-home testing complements well is those tests that are in depth, looking at many things over the course, maybe once in a day or 4 times across the day. So you want to see in-depth measurements of cortisol, androgens, different hormone metabolite pathways, so detox pathways. So the at-home test can actually then complement very well your other test. So I'll give an example of that. Many of these tests want to be during a certain time of the cycle. So for example, a Dutch Complete or Dutch Plus, they done about, they say cycle day 19, 20, 21. Well, what that really means is mid-luteal, about 7 days after you ovulate. Well, cycle day 19, 20, 21 is only mid-luteal for those who ovulate around day 14. And so for anyone who ovulates outside of day 14, then that time is not timed adequately to give you the accurate results that you want. And so you can have the at-home testing be showing you what's happening in this particular cycle so that you can time those more invasive and more comprehensive tests well, so that you don't waste your money on a test that I've heard many perimenopausal patients say this. I did the test and then the next day I got my period. And you're like, well, that then was not mid-luteal. And, maybe you hadn't mailed it in yet, so you can just recollect it. But if you get it in the mailbox and then you get your period and you're like, no, the timing was wrong. Like, how frustrating is that to do the work, to do all this testing and then find out that it was mistimed? And so
But
then
do those tests not take into consideration a perimenopausal woman, or even if you're postmenopause and you have no periods, like there must be some kind of an algorithm to take that into consideration, no?
Well, so I'll show this chart example again to illustrate this point. So if you're trying to establish someone's estrogen detox pathways and you did the test on this particular cycle, on cycle day 21, where this is a chart I showed earlier, it's very low estrogen for about the first 25 days. If we did the test in a low estrogen state, it's going to be hard to establish those estrogen pathways because there's limited estrogen to measure. Versus if you had done that estrogen pathway test the second half of the cycle during the very high estrogen state, you would have proven again, yes, it's high estrogen. And how does my body react to high estrogen? What does it do with it? So that test would be much more useful in this half of the cycle than the other half. So for those patients who are told, do this test, cycle day 19, 20, 21, the first thing we can do to improve that is let's do it after you ovulate. Mid-luteal is truly 5 to 7 days after you ovulate. If you're someone like this example where they're not ovulating, I believe Dutch would say anytime during this high estrogen is a perfect time to test, even though it's not after ovulation, because you're going to be capturing what you want, which is your estrogen detox pathways. So you really can, again, get more information that you're wanting if you have the context of the cycle. And if you're doing one of these more invasive or more comprehensive, expensive tests, it's quite easy to do these at the same time and then have it be more useful in the end.
Ah, that makes perfect sense. Yes, because they are very comprehensive. It tells you so
Hmm.
much and it gives you so much information. And because they're so expensive, people do this maybe once a year, once every two
Hmm.
years. You can't do this stuff regularly. And they're like $500 or something. And then you need like
Yeah.
pay another several $100s for a doctor or practitioner to read it and interpret it for you.
Sure.
So it's a pretty heavy investment for most women. And although it's useful, it is very limiting. And so that's the frustration. If you don't do it at the right time, and then like, oh, she spent all this money for something that's maybe not exactly accurate.
Yeah, and it's one of those things where you don't want to get a test back and then have to question yourself, is this what I really was experiencing, or was that just a one-off? This cycle maybe is not what I'm consistently experiencing. And so how much can I use this data to, change what I'm doing? Whereas even if you go back to this chart example, maybe this isn't the pattern that you were experiencing last month, but this is what you experience right now. It's true. And now you can, again, layer that data together. So when you experience high estrogen again in the future, this is what my body does when I have high estrogen. So it really, again, enhances what you're doing.
Okay, let me see your face again. I'm talking to a chart.
There we go.
Okay, so the thing though is, especially in perimenopause,
Hmm.
one cycle may be completely different than another cycle. Is that true?
Correct. Yes, that's actually one of
So,
the reasons why it matters so much to know what's happening cycle after cycle, or longitudinal data. Because if we think about a perimenopausal patient, she comes in with a list of complaints, and then she gets given one treatment recommendation, and then they go down that pathway, and maybe they feel better, maybe they don't. How do we decide what we change? Because if all we have is symptoms, you don't know if the therapy was working because you address the problem. So in the example I was showing, they currently had low estrogen, you give them estrogen, they feel better. Now, in a month, 6 months, 2 years, they don't feel better. Is it because the hormones changed? Is it because of other contributing factors that are compounding it? If you don't have the hormones and don't have any data about it, you have no idea. It's really a lot of trial and error. If you have the hormones, then oh, this completely changed. Her pattern changed. So now she has her own estrogen production. So I have some chart examples of this where a woman is trending and tracking her duration through her perimenopausal transition. Do you want me to flip into that chart
yes,
example? Okay, so let's go to
yes, I
hers.
love charts.
I love
See these,
charts too.
it's all
Okay,
data.
so lots of data. Now let me just really fast. Yes. Okay, so I have two charts about her. Let me get it. Okay, so
Oh,
let's.
well. She's got a long cycle.
Yeah, so this is a woman experiencing her perimenopausal transition. She's 53. She is choosing not to do HRT for her own reasons, and she is tracking her transition through. So her history is she was having regular cycles. She started having worsening perimenopause symptoms in early 2025, but she noticed that when she started feeling the worst is when this cycle, September. And so for those who can't see the chart, what she was experiencing in September is very high FSH, high LH, which are both from the brain. So the brain is communicating to the ovary is not responding. And I know it's not responding because her estrogen is low. It's not dynamically changing towards ovulation like it would in an ovulatory cycle. And she has no progesterone. So anovulatory pattern. And with this, she really noticed that when her hormones change, her symptoms change. So this is where it gets really fun. So again, she's following her cycles as they go. This is an 80-day cycle, but she didn't get a period at 80 days. It just kept going and going and going. And so I'm showing you and jumping forward. Now she was on cycle day 161 all the way to 200. So her
Oh,
cycle
wow.
ended up being 200 days long, which those in the room that are in perimenopause, you're thinking, I'm getting so close to the year mark without a period. But then she gets a period. So now she has to start her count over. But what did she experience? So if you look here, this pattern completely changed. She now has lowering of FSH, increasing estrogen. This is without hormone therapy. So this is her natural body going through her transition. And she watched her symptoms improve. So her hot flashes, her night sweats improved when her FSH came down and her estradiol came up. And I know many of us understand the importance of estradiol, but what's lacking is many people don't know the importance of FSH. FSH actually carries a lot of risk factors independent of estradiol. So we really need to focus not just on estradiol, but also FSH. So for those who can't see the slide, I'm showing some research around FSH values independent of estradiol having outcomes related to. So high FSH has negative implications for fracture risk and overall bone health. It has negative implications for cardiovascular and neurological. And we think those are some of the most important things, right? So of course we want people to feel better, but not just feel better, we want to reduce their negative outcomes of the perimenopausal transition.
So FSH, in case people are curious, what is that? It's follicle stimulating hormone, right? And this is where the brain is telling the ovaries to get to work. So let's stimulate some follicles. Let's make some estrogen. And usually when we see estrogen increasing on a blood draw, then we see FSH decreasing because it doesn't need to scream so loud, right? So, yes. But interesting that you're saying, because everything you're saying, that the low FSH has risk factors, negative risk factors to high FSH. Yes. Sorry, high FSH. Not, it's low estrogen we always talk about, but high FSH, meaning you're at risk for the bone, heart, and brain. And we would usually say that about estrogen. So aren't we just saying the same thing? Low estrogen equals high FSH, or is that it doesn't always work that way?
Well, so that's where it gets really fascinating because we've always just looked at estrogen. But if we think about a perimenopausal patient, they can have this kind of creeping up of FSH before they get the lowering of estradiol. And so are we kind of focused on the wrong thing? So increasing FSH is really, previously looked at as a screening tool. You get your FSH drawn, it's elevated. Yeah, you're in perimenopause. But should we flip the narrative here and instead say, is this telling something that we should pay attention to? And my argument is it is. In the past, it's been completely ignored. So I'll give a quick chart example here. As you've probably noticed, I talk in chart examples. So doctors, I think in the past, wouldn't they measure the FSH to see if you're close to menopause or if you're in menopause, and they would say, oh, if you're over X number, then you are definitely in menopause, or do they not do that? So if someone's checking to see if they're in perimenopause, I've heard different things done, but sometimes they'll draw FSH, wait at least 6 weeks and draw it again. And if they're both elevated, then you now have been told you're in perimenopause. For the
sorry, go ahead.
So anything in serum, anything above 10 is considered to be out of range. And
so if you're premenopausal, you got to be under meaning not premenopausal. You should be under 10.
Correct. And if you're above 10, then that'll look, sometimes our providers will say, then you have premature ovarian failure, right? So if you think about this from a fertility standpoint, high FSH gets the diagnosis of premature ovarian failure. If you're in an older age, then they just say, well, it's perimenopause, but we don't do anything about it. So in one lens, in fertility, we say it's a problem. But when we think, oh, this one is older now, we just say, yep, it's just perimenopause. So we kind of accept it as is, right? So it's used as a screening tool. If you're elevated, now you're in perimenopause. Well, instead of just thinking of it, you test it, you're elevated, you're in perimenopause, I think what we need to consider instead is, if we find this risk factor, what are we going to do about it? So these are two chart examples where the patient may have gone and got their blood drawn, and the one blood draw that got their FSH was in normal range. So they said, it's normal. But that's not what
perimenopausal woman is. That, sorry, yes. We're looking at a chart of a perimenopausal woman.
Yes, and so this is actually the same patient from earlier that I was showing the 200 day. This was the beginning of her chart, and so this is like the end of her current estrogen. She had estrogen at the beginning of this cycle. That's why her FSH probably was normal. But then her estrogen drops, her FSH goes up. And so we kind of see this switch of the two hormones into this now high FSH state. So she ended up having high FSH for several months in a row before then her FSH comes down and her estradiol goes up. And so again, before we were always just looking at the estradiol only, when really the FSH can give us a much more complete picture of the woman's risk, because low estradiol, yes, has risk, but so does high FSH. And they're not always going to be that perfect one's up, one's down, right? So we can't just say, well, if one is up, then the other is down and assume it's going to be that way. So I will see if I have any chart examples of this, but I don't know if I do off the top of my head
Actually,
here.
in the chart that you just showed, there was one point where estrogen was high on the right of your cursor,
here,
and then
yeah.
also FSH is still rising.
It's still high. Yeah.
Yeah. So when you would suspect it may be going down, maybe it
And
just, yeah, I mean, eventually does, but it takes time.
so really, I use this as a chart example to show like the dysfunction is happening and we can see it versus just waiting for this person to see if she gets a bleed. Like, how long am I going to go without a period? We actually see that the hormone patterns are telling us all the dysfunction is happening, increasing FSH, increasing LH. These are classic signs of hormone dysfunction in perimenopause, and of course, low estrogen as well.
Yeah, when in a normal cycle, you would see that LH have a bump mid-cycle, and then that would be when you're ovulating, right?
Correct. So normally LH is a single event. So I'll show a normal chart example again of what hormones are doing. And so we have the beginning of the cycle. Of course, FSH has a job. It's encouraging follicular recruitment, which we mentioned earlier. It's called the follicle stimulating hormone, FSH. But as Dr. Carrie Jones and I like to joke, it is not a one-trick pony. Like, FSH has much more jobs than just recruiting follicles. So that's why we're seeing there's receptors across the entire body. And that's why there's implications in brain, heart, and bone for high FSH. So in a normal cycle, we want FSH has a small change to recruit a follicle. Then we get the rise and fall of estrogen triggered with then an LH surge for ovulation, and then progesterone goes up. That's what's supposed to happen in a normal cycle. But in perimenopause, we see many dysfunctions. So we have overall maybe lower progesterone than previous in your reproductive years because your corpus luteum, that the ovary's ability to create progesterone, is weakened because of the decline in the quality of your eggs, the aging of the eggs. And so we see things like low progesterone. Then we start seeing dysfunction with lower estradiol or estradiol that doesn't make sense anymore. It's at the wrong time of the cycle. And then we start losing ovulatory cycles. So a woman who has, let's say, in the last 6 months, she's had 3 periods. That's a great metric. But how many times has she ovulated and experienced high progesterone? Maybe it's only 1. So in the last 6 months, she's only had exposure to progesterone 1 time, which we know really the best scenario for hormones is estradiol has its time frame. That's the first half of the cycle. And then progesterone has its time frame, the second half of the cycle. And so when we're going, let's say 6 months with only exposure to estrogen, that actually may be a bigger problem than having low estrogen. And again, we focus so much on this low estrogen.
Well, a woman who's got the elevated estrogen all throughout the cycle will probably also have some symptoms because
Correct.
it's, you know, especially if it's also the ratios between estrogen, progesterone, and maybe other hormones as well. So
yeah, you need to have enough and not at the right times. Each one should do their job at the right time. And so you can get just, I like to call it unopposed estrogen. I know out there's words of estrogen dominance. Well, there's actually a lot of different variations of, I'll say, out of place estrogen. And so in this example, the patient who's 49, she has what I would call unopposed estrogen because she has no ovulatory event and no progesterone. And so estrogen just kind of running the show, and she gets, these 3 weeks of really high estrogen that's no longer making sense. It's not within an ovulatory pattern. And so yes, of course, this is going to lead to symptoms, potentially a very heavy bleed after this, not good things.
What is a woman with this chart that you're showing where all the markers are low except estrogen being high? What is the typical symptoms that a woman would be feeling or seeing?
Well, yeah, I like to be careful with typical because everyone experiences different things. So some women can experience, let's say, breast tenderness because of high estrogen, but some women experience it because of low progesterone. And so those two may be related to each other. High estrogen without enough progesterone. This person could experience a heavy bleed afterwards if we think if this estradiol is building the lining and building and building and building, and then there's no progesterone to mature that lining and thin it out. And, what progesterone is supposed to be doing is getting ready for implantation. So if there's no progesterone happening to that uterine lining, and then it sheds that lining, it can cause heavy bleeding, flooding, and some of those things that women experience. So I always encourage people to track their symptoms based on their hormone pattern, because yes, there are some generalizations that we can make, but those generalizations were also based on limited information about the hormones. So we were probably overgeneralizing. And so I really want to know for you, when do you experience symptoms? Because Some patients, for example, will experience a headache on high estrogen, whereas some will experience a headache based on the dropping of estrogen. And so it really matters more what you experience with your hormones versus the general population.
Okay, this is super useful. So this is where tracking things day by day, like a continuous glucose monitor, it makes so much sense. And I appreciate that you've really clarified that just because you have high estrogen, low progesterone, two women can have completely different symptoms. And this is why knowing your own patterns and your own symptoms matching with those patterns is just gold. And we just can't do that with a blood test every so often.
No, we can't. So it really is that analogy of a CGM to the hormone at home tracking, right? Because we can label certain things. Let's talk about food items. We can, of course, label something like a sugared up beverage. That's going to spike everyone's blood sugar. But how does it affect you specifically? And you can experiment with that and say, when I eat a sweet potato by itself, my blood sugar spikes and it takes me a long time to normalize. But if I eat a sweet potato and I have protein first, then my blood sugar is fine. I don't spike like I did before. So you really can personalize yourself what eating certain things do for you. And I'm just going to add another layer of complexity for those who are still ovulating. How you respond to food before you ovulate and after you ovulate can be different. And so you can even learn, right? So if we think about before you ovulate, that's a time frame generally where estrogen is the king, or I should say queen. So estrogen is running the show. And estrogen makes you slightly more insulin sensitive. So glucose generally is more well maintained. When you move to your after ovulation state, now progesterone is the queen. And high progesterone, if we think about progesterone's job, the word, if you break it down, is progestation, pro-pregnancy. It's intending for implantation and potential pregnancy. And so your body actually wants to kind of promote growth. And so it's going to allow glucose to be a little bit more in the bloodstream a little more. And so we don't have as tight of control over our glucose in our luteal phase after we ovulate. And so our metabolism, everything about us changes after we ovulate because of that high progesterone state. But if we know that about ourselves, we can take purposeful action. And so, after you ovulate, you have a slight insulin resistance or slightly less insulin sensitive. And so you can take purposeful action. Maybe in your luteal phase, I'm going to make sure I have more protein, or I'm not going to go too far in between meals. I'm going to make sure I maybe limit carbs now, or at least don't have carbs on an empty stomach, because how I respond will be different after I ovulate. And in the perimenopausal patient, that's super important to know because our hormone patterns no longer are what they used to be. And so we know with age, we have already weakening insulin sensitivity. And so add on top of it that our hormones are not doing what they used to do. And so a lot of things change that if we understand these things, we can take purposeful action to kind of work against them.
Okay, since we're on the topic on testing, and we're talking about testing hormones, and we're talking about urine testing specifically with these charts, but what about other testing for women in perimenopause? If they're curious, the question a lot of women ask is, oh, can I test if I'm in perimenopause, or can I test when menopause is coming? But there are other tests too that should be looked at. Those, you can answer that question yourself if you think that's a possibility or not, but also what other kind of tests should a woman look at as she's going through this transition?
Yeah, this is definitely the time frame where you want to get a lot of metrics on yourself because, this is a good time to check and ensure that things like your cortisol, your adrenals, and your thyroid function, your insulin levels are all within check, because what you used to do maybe in your 20s and 30s worked, but now in your 30s, late 30s, and your 40s and 50s, it may not work anymore. And so knowing where you are at and where you're moving, this is a time frame where I think blood work more often is necessary. So hormone patterns, of course, give you that longitudinal measurement of what your hormones are doing, but you'll need to have other testing done as well, because testing your hormones will not tell you at all what your cortisol is. So we definitely need to be checking a lot more things than just the hormones during this time frame.
Why does somebody need to check their cortisol?
Well, so I like the way that Dr. Carrie Jones explains it. She's like, likely in your 20s and 30s, we're a little bit more adaptable. And now your body gets a little bit more stubborn. It's like, no, I'm not going to put up with that anymore. And so our patterns and things that, again, used to work well for us are not the same anymore. And so you might be thinking, I've never had issues with my cortisol, or I've never had issues with my blood sugar or my blood pressure or my cholesterol. But all of those things can change now that you're in the perimenopausal transition. So it's a good time, again, to do a recheck, assess yourself, see where you're at, and then moving forward, you can see, am I moving in the right direction? Or unfortunately, it's continuing on that continuum of getting worse.
I like to test my kids now in their 20s. I'm like, what's it like? Everything's great when everything
Yeah.
should be perfect and they're not complaining, then everything's fine. So I like to know what their baseline is, because I
Of
think
course.
as they age, then we'll know they've always been this way or not. Maybe that's normal for them. And instead of being flagged and this is abnormal, I don't know. That's just the way I think. And I think it'd be great. But as we are going through menopause, because it's such a major biological change and things are happening under the hood that we don't feel. We don't feel our bones getting
Correct.
brittle. So I always recommend getting your bones tested or screened. And we don't feel our heart getting full of plaque. So it's good to get some cardiovascular markers. And you're spot on about the insulin and the thyroid and the adrenal and the cortisol, because we don't know if it's hormonal or if it's, I mean, those are hormones actually,
Yes,
but
yes.
if those are your sex hormones or these other hormones that could be at play, because maybe you're still like far from perimenopause or menopause, or you're just early perimenopause and it's maybe your thyroid, not your estrogen or progesterone or something that like that. So it's really good, I think, to get all these, a good baseline of testing. And then as you go through this transition, you can screen whenever your doctor recommends, or as you see change. Because bones, for example, you got to test every year. You can't test sooner than that. Usually they don't change that fast.
Yeah.
But you don't want to wake up at 65 with a fracture and go, holy moly, I didn't even know my bones were
What was
brittle.
happening? Yep.
Yeah.
Exactly.
So this is great. But going back to the question about, can you test if you're in perimenopause? That answer would be yes.
Testing your hormones.
Well, can you if somebody asks the question, how, I mean, it sounds like with this urine testing, you can, whereas before you couldn't. And so that's why, I mean, before when people would say, can I test if I'm in perimenopause? I'd be like, well, not really. I think you just go by your symptoms and your age and things like that. But I think I'm wrong now.
Yeah, the tide has turned finally. And so anytime someone says, like, can I test my hormones? I mean, my questions are very basic. Do you have ovaries? And are you between puberty and menopause? And the answer is always yes. You can test. If you are postmenopausal, if you want to know what your metrics are, you can. But what we expect to find, if you are not on HRT, we expect to find low estrogen, low progesterone, and then high FSH. And I'll say LH is a little bit unpredictable, what we'll find. Some patients we find high LH, some people we find more moderate, and some people we still find low. And so that has really not been studied well for a duration of time for someone who's postmenopausal. So that's what we expect to find in someone not treating it. But what if you are choosing to do HRT or purposeful action to change those hormones? Well, then you also can test. So I always encourage people to consider, if you're doing something to change your outcome in menopause, I know that we're seeking to feel better, but is that all that you really want? Or are you also looking to improve your overall health? So if the answer is yes, you want to know what your overall health is and how can I improve it, then using something like the at-home hormone monitoring testing really can show you, am I absorbing my estrogen well? And is it changing my FSH? Because just being on, let's say, an estradiol patch, it may make you feel a little bit better and you're like, okay, I achieved my goal. But if you didn't actually raise your estradiol very much, are you protecting your bone? And if you haven't reduced your FSH, you haven't actually removed that risk factor that you have. So I'm trying to draw attention to that it's not enough. I don't want to say good enough. We don't want to just be good enough. We want to be optimal. And so this really does, much more research needs to happen. But we know, again, research says high FSH carries risk of bone, brain, and heart. And that estrogen that you're on may not have actually changed that risk of high FSH. So some providers, for example, are now using FSH to help to paint the picture of, is my HRT optimized? Is what I'm on or what my patient's on really what's best for them?
You're absolutely right. I'm always talking about protecting my 80-year-old self, because she's really depending on the decisions that I make today, because
Yes.
all these diseases of aging don't start when she's 80. She starts decades before. And that's why menopause is like this ultimate opportunity to protect our future self. And that's the testing, I think, is part of it, because there's things that we just don't feel, we don't see. And only testing and looking under the hood can reveal some trends. And then over time, you'll see, are you trending in the wrong direction or in the right direction? So I really like that. But let's then dive into because we're talking about levels and hormones, and we're talking this urine at home urine test kit, and the one that I'm using is the Mira, and I guess there are others, I don't know, but this is the one that I've heard from Dr. Carrie Jones, and I really wanted to have this conversation with you because you work with Mira and you understand this device, and I am blown away. And I had it for a while, for months, sitting on my drawer, and I'm like, thinking I'm going to have to spend all this time to like learn it, but it's so easy. And so I have had so many questions about it because as I'm going through it, I know what blood levels should know, the numbers that are where I like and I feel my best. And then I get numbers on a chart in an app. So actually, let's pause here for a second. Do you have the device in front of you to show?
Yeah, I can show people exactly what this is. So it's an at-home device. So you purchase it, the device gets mailed to your home. It's a standalone device, so it does not require like a computer or a phone to run the device. It's its own entity.
It's the size of an egg. I mean, just to give you a visual, it looks like an egg.
Yes, it looks like an egg. It fits in the palm of your hand. It's called like the at-home, like lab in your home. I always joke this is the first time that like your clinicians can join you in the bathroom because you're collecting first morning urine samples. And so you collect a sample, you open up one of your test strips, you dip it for 20 seconds, you cap it, you put it in the machine. Like that's the time investment that you have to do for it. Then the device reads it. It takes 16 minutes to get a result. It beeps when it's done. You open your phone app. It transmits the data over via Bluetooth into a graph. As soon as you as the user see the data in your graph, your clinician, if you're set up with one, can see it as well. So they can see, if you're about to have a visit, and I've seen clinicians do this, they pull it open on their, computer screen in the doctor's office or via telemedicine visit, and you go through it together. And if you've been tracking your symptoms, now you have hormone data, symptoms together, you can start doing those correlations and saying, I felt best here and I felt worst here. And then you can start seeing, are these symptoms correlated with your hormones or not? Because not all of them will be. Maybe that symptom that you're having is related to your abnormal cortisol more than your abnormal, let's say, estradiol pattern. So you can't blame everything on estrogen, progesterone, LH, and FSH. You have lots of other hormones in your body. And so you really can start learning yourself. And that's where I was talking before about someone who learns when their hormones drop right before their period, that's when they feel the worst. Or for the next person, it's as their estrogen is climbing rapidly towards ovulation, that's when they feel the worst. So everyone can learn more about themselves. So even if you're not going to do anything about it, if you understand, and plot it out, like I'm probably not going to feel well tomorrow, you can live your life differently and you can have a better experience just because you're more prepared for it. So,
yeah, and you also have a little notes section, which I think is great. I mean, you have actually, it's similar to some other maybe menopause trackers, and you can say what your bleed is like and how you feel and if you had sex and what your mood is like. And then there's a notes section, and I use that notes section a lot, and I just take all my notes so that I can go back and say, okay, what was happening next? I forget. And what was I taking? Because I'm taking hormone therapy. I'm not in period. Well, I still think I'm in period. I don't know. I've been taking hormones since I had a regular period, so I will never know my menopause birth date, but I can see the hormones if I'm absorbing them or not absorbing them and correlate them to how I'm feeling. Because the reason I picked this up finally off my bedside table is because I was changing my hormone dosage and it wasn't working. I'm like, what is wrong? I don't understand. And I now can see that what I was taking was not absorbing. And that was insane. And so then I changed to delivery methods, even as I changed delivery routes. If I put it on my inner thigh or if I put it vaginally or if I take it orally, like I can see different patterns, which is really mind blowing. And so now I know the pattern when I feel my best. So this is the insight, because when I originally, another reason I sort of put this to the side is when I first got it is because I thought, oh, this is a fertility device, or this is for women in perimenopause who are not taking hormones. But I realized actually I'd still get a lot of insight.
Yeah. And it's really, again, you learning yourself, because you know yourself the best. You know when you feel your best, and no one else can really, track that for you. You have to keep track of it. And then devices like this really help you learn about yourself and learn, I've had people learn for themselves, like they knew maybe X, Y, and Z made them feel bad, but now they actually see it in the hormones. They're like, oh, I was doing that to myself, right? Like when I'm trying to think of an example, when I stayed up late multiple nights in a row, and then I missed a dose. Like they knew that wasn't ideal, but when you see it in the hormones and you're like, I really need to stop doing that. So it can teach you things about yourself. It can really challenge you sometimes. Like, I need to take care of myself better. I see this with patients with like PMOS, or previously called PCOS, where they're doing so well and then they start falling off the bandwagon. And, in the past, they really would see the outcome if their period was late. Well, now they see that change in the hormones and they're like, oh no, I better get back on it because I see my hormones are getting out of coordination again. And they don't have to wait, months to find out that a bleed came really late. Instead, they actually see the hormone patterns change. And that can be for the negative or the positive. I see that too with people who are like, when I am, doing X, Y, and Z, my hormones just look so much better. And, that's a motivator.
It is. It does help a lot. And I want to understand the numbers though, because they're little numbers that you get on this. And I guess I mentioned before, I know what my estradiol usually is I feel pretty good at 200 picograms per ml. So when I see a number though on the Mira device and the app, it's also it'll be somewhere around the 200, but I know this is urine metabolites. It's not blood. So how closely can that estradiol and the FSH level and the progesterone, which is another story, how does that correlate? Can I correlate it to the blood?
Yeah, so there is a large third-party study that's about to be published on Mira data specifically. So the researcher chose Mira as the product. They did serum values, ultrasounds, and Mira all at the same time. And so we expect it to be published in the next couple of weeks. So you should be able to look it up soon. But it's really proving what's already been proven, but in a larger scale, that urinary metabolites do correlate with serum. But they are each measured differently. So I want to be very clear that if someone does their serum value, and they're like, my serum is 100, and then they measure on Mira and it's not 100, people automatically think they don't correlate with each other. Well, they each have their own reference range. So is estradiol of 100, is that at ovulation? Then I would consider it low. Is it at cycle day 3? Then you're going to interpret it differently. So you interpret the serum by itself based on what part of the cycle you're in, and then you interpret the urinary metabolite on its own based on where you are in the cycle as well. And so we provide a reference range that shows you exactly what a normal pattern of estrogen, for example, is. So if on serum you find your hormones are low, on Mira you find your hormones are low, in their own respective reference range, you have two things telling you your hormones are low. So they correlate with each other. But if they don't match, because this can happen, I need people to understand that the serum happens first, then the urinary metabolite. So if you're not measuring them on the same day, you really can't try to correlate them at all because your hormones change. And even within the same day, the serum happens first and then the urinary metabolite. So it's much better if you're going to try to do a correlation like that to do ideally 2 days in a row, the urinary metabolites, and 2 days in a row of serum. So you have multiple data points looking at where you're going. And then finally, if they don't match, then we have to consider, I don't want to get too complicated here, but there is the circulating hormone is one thing. But did your body metabolize it and utilize it and then excrete it into the urinary metabolite? Because having the hormone and using it are also two different things. And so we also have to consider that.
You're right. Absolutely. Because can get so complex. And I did remember when I first started Mira and I decided I was very low in estrogen and I went to test and it also came low. So for me, I was like, oh, interesting. It's correlated. I don't remember the exact numbers, but I know it's like, I feel low. And now I feel good. And I see in the Mira that the estrogen levels are high. So I'm going to test and I'm going to expect it to be high. And I'm going to see it's pretty, that's talking about estrogen. But when I take the progesterone, and in the chart too, you could see the women who were taking an oral progesterone, it went off the charts. It was like, oh, it's like, it can't even be counted because this is a hormone that we're taking. It's not our own progesterone. And we're usually taking it orally.
If you take oral progesterone, then when your body digests it and metabolizes it, the first pass through your liver creates PDG, which is what Mira measures. And so in that situation, you're not seeing what your own endogenous levels are. You're actually seeing that, yes, you took one and it's being, your body's breaking it down. And so unfortunately, oral progesterone makes it so you can't measure your own values anymore. But there's still utilization of those measurements, because if you're taking that oral progesterone and you were having, let's say, coordinated hormones, rise and fall of estrogen with an LH surge, and now that you start progesterone, you're not, what you just took had an effect on the other hormones. So continuing to track is still very helpful. You just need to know, what are you looking for? What are you trying to assess here? And so if I can show this chart example, this is an example of estrogen with the reference range. And so this is clinicians that are set up with us can view the user data with this reference range behind it. And so as you can see, this person has low E3G, low estrogen. And so this person who is actually ovulating, so I'll go show you LH for a second. She is having her LH surge very clearly. She's triggering to ovulate, but her estrogen is not doing what it's supposed to. So it's not dynamically changing. And so this would be someone, if I were kind of analyzing this chart and giving the summary, I would conclude this person is ovulating, but her estrogen levels are low and not dynamic at ovulation. So we're just having an ovulatory cycle is still not enough. And that's what I really want people to know is just having a bleed is not enough. Just ovulating is not enough. The actual hormone patterns matter. Because if you're experiencing low estrogen in an ovulatory cycle, you're likely going to have symptoms. And likely, if you're not getting good estrogen, you're probably not going to get good progesterone either, because a good follicle, a good egg is what then creates the corpus luteum to make progesterone for you. So, again, all these hormones matter.
Yeah. Oh God, it's so interesting. It's so interesting. So I'm just fascinated and I'm so grateful. I mean, I love the CGM to look at my blood sugar, and now I'm just loving that I can track every single day for months on end. So this is actually brilliant. The ultimate, I guess, dream would be to have like a continuous glucose, like a continuous monitor on my body, so that I don't need to actually pee in a cup and put it in every day and then see the pattern throughout the day. Is that something that's happening in the future?
Yeah, researchers are definitely looking into this. I will say, I suspect it's still a couple of years out, so don't hold your breath for it. It's going to take a little bit of time. But yes, there is research looking at, can we track the hormones the similar way that we track glucose in a CGM? And of course, there's also other measurements that we're considering. So can we measure cortisol at home? Can we measure testosterone at home? What about melatonin? Like, what other things can we measure that are going to improve patient outcomes because they can see how their hormones are acting? So it's super exciting to be in this time frame where it's becoming common that patients get access to their own information, and they don't have to have a doctor prescribe it or order it or be limited to how often it gets checked. It's now much more widely accepted. And also wearables are really making it so we can stack up this data together. So you can see how your sleep and your exercise recovery, let's do like your heart rate variability, your hormone data, all are working together to, of course, be who you are.
Yeah, actually, I noticed I connected my Aura ring, my smart ring. It measures all these biomarkers that you just mentioned, and it's in the Mira app. Like, that's just amazing.
Yeah, so we're seeing that's one integration that we have, but we're from like a clinician side, there's other bigger integrations. I say bigger, like pulling many things into one place, which is really helping clinicians to see for themselves. There's one, I can't say it out loud yet, but one patient-facing integration that will be coming where patients will be able to see multiple data points all at the same time as well. So it's an exciting time. Really, again, I love the patient empowerment piece of patients being able to see their data, make action for themselves, and then use it to have better conversations with their clinicians and have better outcomes.
Okay, so you're going to have to share. People are maybe wondering, okay, I want to get the Mira. How much does this cost? Where do they get it? Can they get it? And what do they need to know about that?
Yeah, Mira is a direct-to-consumer product, so you can just go to miracare.com and purchase it. If you have a clinician that you're working with, then you have the added benefit that they can see your data in real time as well. So I believe that will you be sharing your discount code in the chat?
Yes, actually, I do. I have 2 hack for 30% off the supplies, like the sticks. It could be combined with a wand subscription for nearly 40% off the wands. And then I've got another code called 2hack15, and that's 15% off one-time purchases. And I'll have links to that in the show notes, because I know it sounds confusing. Like, what? 2hack 15?
Yes.
I'll put that in the show notes.
Well, and hopefully we'll have the editor crop this because I'll edit it for you really fast. The 15% we increased to 20. And
cool.
So it's still the same code. It still has 2 and the 15 at the end. And then the other code, the 30% off, we only share that with like your community. So not on the podcast. Sorry.
Okay.
So the 30% is meant for, we'll edit that part out. So if you want to say it again, anyone listening can use the 20% off. And then if you want to share that, if you're set up with a clinician, they can give you an additional 10% off. So if you want to.
Oh, wow.
Or if you want me to say
amazing.
It's up to you.
Yes. Well, you say it. Yeah.
Okay. Yeah. So As an added benefit to, let me start over, sorry. So if you're interested in purchasing Mira, you just go to miracare.com to purchase it. We will be sharing with you a 20% discount code. It'll be written in the show notes for you. And if you want to say it out loud for those that want to hear it really fast, I'll let you say it.
It's 2HACK15, even though it's 20% off. Is that correct?
Yes. Yes. So 2HACK15 will give everyone 20% off to make your purchase. If you are working with a clinician, you get an added 10% off. So it'll actually be 30%. So again, if you have a clinician, please check with them if they have a Mira discount code, because then you can get a higher discount. And as I've shared before, your clinician can see your data as well. So it really can improve your outcomes if both you and your clinician can see it. And if you want more information, go to the show notes and we'll have things you can click on.
Oh, excellent. Yes, we will have everything that you need to know. We also have your Instagram and your Facebook, YouTube, LinkedIn, everything at your website, miracare.com. And anybody who's in my Biohacking Menopause membership groups, the private women's only menopause support group, I will support you there. I will share my codes there. And you can also share your data with me so we can go through all this together. And we can get people like Rosemary when we have extra questions and we have things you need to know right away to support you there with that. So please, I'll have a link to Biohacking Menopause membership in the show notes as well. So please join us there. My last question then to you is if a woman listening to this is in perimenopause, she's really frustrated by testing that hasn't given her real answers and really trying to figure out what her next step is, what would you actually recommend that she do?
So if you're someone who feels like you don't have the answers, you don't have what you need, then it may be time to get more longitudinal data. Let's get your hormones tested in a way that shows you truly what's happening, whether that be you're brand new to perimenopause, you just got, told you're in perimenopause, or if you're someone who has already been told you're in menopause, but you're on HRT, this is a useful tool for you to see truly what's happening. And I don't want to exclude people that think, well, maybe I don't fit this because I've had a hysterectomy or a uterine ablation, or maybe I have an IUD in place. You also can test, because if you have ovaries, then you can still test your hormones, especially those patients. Just because you don't have a bleed, that doesn't mean your hormones aren't changing. And so you may feel completely lost because you don't have a menstrual bleed to track, but your hormones are changing, and let's test them and find out what's going on for you. So next steps, purchase the Mira supplies, begin testing. As you were mentioning earlier, if it sits there on the shelf, you learn nothing. So make sure when you buy it that you actually start testing. So open it up, plug it in, get it charged, download the app. It's very simple. Just follow the instructions on how to test. And you don't have to wait for a certain time frame, a certain event to happen to begin testing. You just start testing the day after you get the supplies. And then you can either follow the app's prompting when it tells you to test, or just start testing daily. Or if you're on a budget and you want to test less often, maybe every other day is better for you. It's completely versatile, flexible to your situation. Just start testing so you can learn about your hormones.
Yeah, it doesn't take an hour to learn. You don't need to put aside an hour like they did.
No.
The one question that if a woman has had a hysterectomy with her ovaries removed, but is on HRT, would it be useful?
If she wants to track her FSH and estrogen absorption, yes. So those are the two things that would still be useful if we want to see evidence of estrogen absorption. And is that estrogen therapy changing her FSH? Yes.
Got it. And does this ship internationally? Can people get it only
yes.
in the US?
Yep, Mira's available internationally. Really, the only difference is it takes a little bit more of a ship time if you are in more of a remote area, I will say. But we have distribution centers in the US and Canada and in Europe.
Oh, great. And the app works on all types of mobile phones, Android
Correct.
and Apple.
Yep. And the app is free. There's no subscriptions. There's no added cost to you. It's a one-time cost of the device, and then the ongoing cost to replace the one. So you buy the packs of ones in packs of either 20 or 30. So if you buy a pack of 30, you could test for the next 30 days straight, or you could test every other day for the next 60 days. That's up to you. And you decide, of course, how many boxes of ones you want to buy. So like an easy start would be the device and 2 boxes of ones, because now you have enough to get you through 2 months or even maybe 4 months. If you're testing less often, and you'll get a lot of information on yourself.
Oh, cool. Well, I forgot the price of the device. Did you mention that?
Oh, yeah. Sorry. I did fail to tell you. So the device plus 30 ones will cost retail $269. And again, you'll get that 20% off. So the initial investment, is less than some single blood tests, half the cost of some of these more like the Dutch Complete or Dutch Plus, something like that.
Yes, so much more reasonable. And you can do a lot with this. So thank you so much, Rosemary. You're so patient with me and my questions. And I know we have a great relationship and see you more in our community. And I appreciate all the work that you do and the charts and everything you've put together. I encourage everyone to please go to YouTube if you haven't already. And thank you so much for getting to the end of this podcast. We wouldn't be here without you. Really appreciate you spending the time, just the three of us, right? So thank you, Rosemary, for your time. And I'm sure we're going to see you again. Take care.
Yes, thank you.